So today we're going to discuss a topic called esophageal atresia, and that comes in the category of congenital malformations. What happens in esophageal atresia is that basically you have an atretic segment in which you do not have communication of that part of the hollow viscus with the distal part. So there are different types of it, but the one which they've discussed here, which is the most common one, is the one in which esophagus basically ends in a blind pouch, which is what we can see here. And as far as the distal part of the esophagus is concerned, that gets communicated with the trachea, and that makes a tracheoesophageal fistula. So this type in which you have a proximal pouch which is blindly ending, and you have a distal part which is communicating with the trachea, making it a tracheoesophageal fistula, that is the most common type. What is the presentation? You can have a drooling because the babies are unable to swallow their own saliva. Then you can have a cyanotic episode on attempting to feed. If you feed the baby, that will go into the trachea and lung, leading to the cough as well as cyanotic spells. So that could be one presentation. Some of the babies can have polyhydramnios. During antenatal life, the babies, they swallow the amniotic fluid, and as they fail to do that in this condition, that will lead to polyhydramnios. These could be the possible three presentations. If you do some investigation or some examination, that could also confirm your diagnosis. For example, if you pass the NG tube, that will go no further than the upper esophageal pouch. And if you get the X-ray, you will see the NG tube curled up here as well. That could also determine the reason. And if you get a chest X-ray or the abdominal X-ray done, you would find a lot of air in the stomach. Reason is whatever you're breathing in, that is going from trachea into the stomach. So you would find a huge gastric bubble. So that's what you find out on examination as well as investigation. Chest X-ray and abdominal chest X-ray, you will have abdominal gas. Then comes some of the anomalies which you can have it with this condition. That could be cardiac problems, that could be skeletal problems, or the renal problems. So obviously it's a congenital condition that can have other problems as well as atresia. How are you going to repair it? Normally we have a right-sided approach in such patients. You perform thoracotomy. But in case if you want to do a thoracoscopic repair, you can do that. But as the Bailey says, it's challenging, but it's also possible, it's feasible. Normally you do the surgery on day 1 or day 2 of the birth. What do you do in this surgery? The fistula is divided. So this is the fistula. Here you divide it. And obviously if you divide it, then you have an opening here of the trachea that is closed. So trachea and the tracheal side is closed. Then what happens to this distal part? The esophageal ends are anastomosed. The distal part is anastomosed with the proximal part. As the esophagus has a pore supply, so you can always have ischemia as well as necrosis and resulting into the leak. So usually this anastomosis is under tension, and because the esophagus is having a poor blood supply, you can have some of the complications which are mentioned here as anastomotic leak. Number 1, you can have a stricture wherever you have inflammation, wherever you've had a surgery done. You can have a stricture as one of the outcome. You can have a fistula formation again, which is called as a recurrent fistula formation. The fourth complication which we can have is the gastroesophageal reflux. So this is one of the complications. You can face it in such patients who underwent surgery. Infants with pure esophageal atresia and no tracheoesophageal fistula are usually best managed by a temporary gastrostomy. In case if you've had a condition where you do not have a communication with the trachea, this ends here and this ends, the distal part ends or basically is closed from the top, you need not to go for this surgery. All you're going to do is, first of all, you're going to make a temporary gastrostomy. You're going to make a communication of the stomach for the feeding. And then later you can do the repair. Once the baby is little grown up, then you can, little grown means like after a few days or a week, you can go for the repair. In case if the segment was too big and you have a space and you cannot just primarily close it, in that particular case, you're going to go for the esophageal replacement. You're going to have a replacement segment in here. So or in esophageal replacement. These are all the options which you can undergo, considering whatever the circumstances are. Except for very low birth weight babies and those with major congenital heart disease, most infants with repaired esophageal atresia have a good prognosis. So it has a very good prognosis, as the belly says.